Hello, my name is Dinithi, and today I will be speaking about the longitudinal associations between mild behavioral impairment, sleep disturbances, and progression to dementia. The study was funded by Alberta Innovates. So dementia is currently the 7th leading cause of death worldwide. However, clinical trials for the most prevalent type of dementia, Alzheimer's disease, have been unsuccessful partly because they intervene too late in the disease course. So there's a crucial need for the improved detection of older adults at risk for dementia to facilitate the development of therapeutic and preventative interventions. In light of this, the 5th Canadian Consensus Conference on Diagnosis and Treatment of Dementia recommended the use of non-cognitive markers of dementia for improved dementia detection. Two of these markers were mild behavioral impairment and sleep disturbance. Mild behavioral impairment, or MBI, is a neurobehavioral syndrome aimed at capturing the emergence of persistent neuropsychiatric symptoms, or NPS, in older adults. These NPS represent a change from long-standing behavior or personality, which indicates an at-risk state for incident cognitive decline and dementia. Several studies have indicated that MBI is associated with greater cognitive decline and the development of dementia. According to the National Library of Medicine, sleep disturbances can include difficulties initiating and maintaining sleep, excessive drowsiness, irregularities in sleep-wake cycle, in addition to several other conditions. For this study, we used a very commonly used measure of sleep disturbances within older adults, the MPIQ nighttime behaviors variable. This variable is a single question asking an informant whether the patient awakens them during the night, rises too early in the morning, or takes excessive naps. Several studies have also indicated that sleep disturbances were associated with greater cognitive decline, leading to dementia. However, the relationship between MBI and sleep disturbance and their combined ability to predict dementia is poorly understood. In light of this, we aim to determine whether those experiencing MBI at baseline would have a greater hazard of developing sleep disturbances in the future, and vice versa. Several studies have also shown that people with sleep disturbances are more likely to develop dementia, and our study aimed to replicate these findings. In addition, as MBI is also predictive of dementia, we explored whether layering MBI on top of sleep disturbances would increase the risk of developing dementia and improve our prediction. So we hypothesized that older adults with MBI will be more likely to develop sleep disturbances than those without, and vice versa. Additionally, we hypothesized that those with sleep disturbances will be more likely to develop dementia, and those with both sleep disturbances and MBI will be even more likely to develop dementia. To conduct this study, clinical data from several time points were obtained from the uniform dataset made available by the National Alzheimer's Coordinating Center based in the United States. MBI score was derived from the MPIQ using a published algorithm, and the MPIQ nighttime behaviors item was used to determine presence or absence of sleep disturbance, consistent with previous studies. Lastly, the clinician diagnosis in the NAC-UDS was used to determine the cognitive status, whether the patient was cognitively normal, had mild cognitive impairment, or dementia. Based on the distribution of our data, we used Cox proportional hazard models to predict future MBI, sleep disturbance, and dementia risk. We use age, sex, education, and cognitive diagnosis as our main covariates, as these variables tend to impact dementia prognosis. Aligning with our three aims, our three analyses were to determine the bidirectional association between MBI status and sleep disturbances, which is analyses 1 and 2, and determine the association between sleep disturbance and future dementia, and the association between MBI and future dementia within those with sleep disturbances. Both our unadjusted univariable model and the multivariable model adjusted for covariates indicated the same trends. After adjusting for our covariates, we see that participants with MBI experienced 3.31 times the hazard of developing sleep disturbances relative to those without MBI. In addition, older adults with sleep disturbance at baseline experienced a 2.07 times the hazard of developing MBI than those without sleep disturbance. At baseline, older adults with sleep disturbance were at a 1.43 times the hazard of developing dementia compared to those without sleep disturbance, and layering MBI on top of sleep disturbance in our prediction indicated a 2.46 times the hazard of developing dementia. The study demonstrated a bidirectional relationship between MBI and sleep disturbances. Thus, treating symptoms of MBI may reduce the risk of sleep disturbances and vice versa. Additionally, including MBI in addition to sleep disturbances improves the prediction of future dementia risk. So interventions to mitigate both MBI and sleep disturbances may further reduce dementia risk. All in all, these markers should be incorporated into dementia risk assessments to best aid early detection. With that, I would like to thank my supervisor, Dr. Ismail, and all the lab members for their guidance and mentorship throughout this project. I would also like to thank Alberta Innovates for providing the funding that made this project possible. Thank you.